Of course, we do have our little slide as a reminder that November 1st is coming quickly. And of course, our 100-year celebration. And of course, Dr. Bifes will remember at least some of those years as he's been a senior member of our department. So it is my great pleasure to kick off this morning's actually today's events. And I'll just start by respectfully acknowledging that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community as we look forward on Sunday and Monday to celebrate, of course, our annual Truth and Reconciliation Day. So don't forget to wear your orange shirts. So with that, I'm going to hand it over to Dr. Vliegaftet, who's actually come back from his sabbatical for this day, important day. So over to you, Harry.
Thank you. So I couldn't miss this one, not because I tried to organize it, but because it's for Dean. I mean, Dean has been my mentor for many years. He's still my mentor in a lot of things. So on behalf of the Alberta Respiratory Center also, I want to welcome everyone here today. And although probably most of you know Dean quite well, maybe some people online also, some of our junior colleagues might not know as much about Dean, so I'll say a few things. So Dean grew up in Edmonton, graduated from the University of Alberta before going around the world to train in Toronto, then in Glasgow, UK. He went to Hamilton after that. And then he had faculty positions in Hamilton and at University of Calgary before coming here in '93. He had the AstraZeneca chair in asthma research, and he was the founding kind of director of the Alberta Asthma Center that worked for about 20 years, did great work, and then morphed into the Alberta Respiratory Center that we have these days, again, under the leadership of Dean. Dean now is an emeritus professor, but still very active. He still does research. He still does a lot of mentorship. We see him very often still. I think Marg is still kind of upset with how often she doesn't see him, and we see him here. But so Dean did a lot of basic kind of science work in muscle biology, in neuroimmunology, in inflammation, but also he did a lot of directly clinical work or clinical relevant work with asthma epidemiology and development of programs for asthma education for patients, for physicians, especially through the Asthma Center that have been very successful over the years. And he has published over 300 papers for his research activities. He had many awards, and I have this just to remember the names of the awards. I'm not good with names. So the Jerry Dolovitz Award and the David McCourty Award from lectureship from the Canadian Society of Allergy and Immunology, the Bernard Sinader Award from the Canadian Society for Immunology, the Killam Annual Professorship from the university, and also in 2017, he was elected a fellow of the Canadian Academy of Health Sciences. A big part of what Dean did was really his mentorship through the years for junior colleagues, for trainees, for a lot of us here, a lot of the people that I see here. I know them from back then when we were training with Dean, or I've seen them over the years and know they trained or they were mentored by Dean. And for that also, he got some awards for mentorship, the Killam Award for Excellence in Mentoring and the Lifetime Mentoring Achievement Award from Allergen-NC, that he was a big part of Allergen and he did a lot of work with that. Maybe during the day, a lot of this stuff will show up, kind of thing about Allergen. So I'll finish with saying that he also led a lot of provincial and national programs in kind of respiratory medicine in general. He was the co-lead for Asthma Breathes. That's an initiative maybe 20 years ago, maybe more, in Alberta that actually led to the development of respiratory health strategic clinical network by Alberta Health Services and kind of started organizing respiratory care and respiratory health in Alberta. And he was obviously the lead or co-lead, was in leadership positions always for the Allergen-NC, one of the National Centers of Excellence for Allergy and Asthma. And he was a co-lead for the big cohort that Allergen has developed, the And I can never remember, Canadian Health Infant Longitudinal Development Study. So child, I remember child, but the whole thing is tough to remember. So for all this, I think it's great that we have so many people today for this day that is kind of about Dean. And I'll stop here and I'll have Dr. Forsyth somewhere here to introduce the speaker today.
Good morning, everyone. So the stipulation for a Dean Beefus lecturer is that they are exceptional scientists that has provided cutting-edge insights into mechanisms underlying lung disease. And I think there's absolutely no doubt that today's speaker fits that bill. So Dr. Paul O'Byrne obtained his medical degree at the University College Dublin. He's currently the Dean and Vice President of the Faculty of Health Sciences at McMaster University, and he's a global leader in research into the mechanisms and treatment of asthma. He's published more than 540 peer-reviewed papers. His H-index is 125, and he's had a whole range of awards and accolades throughout his career. So he's a member of the Royal Society of Canada. He has had medals and awards from the European Respiratory Society. His election to the Canadian Academy of Health Sciences. He was named a Giant of Chest Medicine by the American College of Chest Physicians. And he's received an Honorary Lifetime Achievement Award from the Ontario Thoracic Society. And in 2023, he was appointed an officer of the Order of Canada. And so with that, it gives me really great pleasure to invite Dr. Paul O'Byrne to give this year's Dean Beefus lectureship. Paul?
Thank you so very much for that very thoughtful and generous introduction, Paul. It's lovely to see you again in a different environment. Paul and I worked closely together at McMaster for a number of years, and it's actually wonderful to see so many people that have sort of worked their way through the various places that I've been during my career. It's a particular privilege to be here to recognize and honor Dean Beefus. I was just thrilled when I got the invitation from Harris, who sent me an email and said, "Are you available?" And I said, "No matter what I'm doing, I'm going to be there." So really, really delighted to be here. Dean has been an influence, I think I'll show you, in my career from the very earliest days. And what I'm hoping to show you is that the focus of his research way back when we were both a lot younger has come in a way for me full circle and is now very much a focus of what we're doing right at the moment to try to figure out what's going on with allergic asthma. I do want to start by apologizing to you. I've had some laryngitis for the past 2 days, so I'm hoping my voice projects adequately to particularly the people sitting way, way, way back there. So I want to begin by reminiscing just a little bit. In 1984, I was a postdoctoral fellow at UCSF, at the Cardiovascular Research Institute, working with a bunch of people that were doing work in inflammation in the airways. And every week we had a session to discuss updates in science. Jane Adele and John Clements would be there, who just recently passed away, the man who discovered surfactant. It was a very hot and heavy debate. It was pretty intense, I have to say. And on one of these events in '84, the topic for discussion was the work of Beefus and Bienenstock, and their work in identifying different types of mast cells, phenotyping them, knowing what it means, having tryptase positive, chymase and tryptase positive, where they were, what they do. And I can remember vividly at the time feeling immensely proud that that little place that I had come from, McMaster University, that UCSF probably didn't know a great deal about. These two really amazing scientists were there and were doing cutting edge research that really captured the imagination of these people, in my view, were greats in respiratory medicine. So mast cells way back were a very great major focus of Dean's work, clearly with John when he was in Hamilton. And I'm going to say right now that it's now a few years later, I'll even do the math, a lot of years later. And in my view, we're still very uncertain about just what mast cells can do and do in relation to particularly allergen-induced airway responses. See if I can get this going. I will be discussing some drug development issues today, so it's really important you know my potential for conflict of interest, advisory board, speakers' fees, grants and aid, and probably my greatest conflict is that I'm employed by McMaster University. Looking back at the history of allergen-induced airway responses, which is the topic I'll be touching on today, I'm very grateful for the next 3 or 4 slides to Don Cockcroft. I want to mention Don early on. Don, another colleague from Saskatoon, who actually really got me interested in what's going on in the airways of asthmatics when they're exposed to an environmental allergen. And these slides are taken from a talk Don gave, and I really love the way he does things. But the very first description of grass pollen-induced asthma made by this gentleman, Van Helmont, who described 3 members of a family suffering from asthma only during the summer, and if seasonal other symptoms were worse in the wintertime. He was an asthmatic himself. That's something you'll hear a bit about as I go through this. John Bostock, 1819, gave a more detailed description of grass pollen asthma, case report of himself, and it's the first classic description of grass pollen-induced allergic respiratory disease. He was an asthmatic himself and identified the symptoms in himself. Morrill Weinburn was the first to describe ragweed as an important cause of asthma, autumn allergic rhinitis and asthma, and he, as best I can tell, is the first to actually stimulate an attack in himself by sniffing ragweed and getting an allergic response to that. He was an asthmatic. Grass pollen asthma, Charles Blackley in 1873, once again, actually tested this hypothesis by inhaling grass pollen himself, and he was an asthmatic and was able to do this. And finally, animal allergic asthma, Henry Hyde Saltery, in his very classic treatise on asthma, that's a real classic, in the 3rd edition, described asthma and rhinitis on exposure to cats, rabbits, horses, and dogs. He was an asthmatic. I'm an asthmatic. I've been an asthmatic all my life. Don Cockcroft, an asthmatic. I think you have to be an asthmatic to really get into this business because you know what you're dealing with. You understand what the heck's going on, at least in the way of symptoms. So what I would like to do today is to focus a little bit on this issue of allergic asthma. And since those very early descriptions, we've come a very long way in understanding the immunology and the biology of what's happening in asthmatic airways. We understand the initial antigen recognition, T-cell orientation, and the production of IgE, an issue I'll come back to in a few minutes. We know about mast cells and their important role in inducing the asthmatic responses I'll talk about. Trafficking of dendritic cells into the airway and how they are engaged. The influx of eosinophils, inflammatory cells following an allergen exposure, a topic I thought I understood until about a month ago. I do not anymore, so I want to tell you why that's the case. And then the structural changes in the airway that are associated with permanent asthma, changes in the nerves, the amount of muscle, and the tethering of the airway to the parenchyma. That is, we think, responsible for something called airway hyperresponsiveness, which is a characteristic physiological feature of asthma. Again, I'll come back to that in a little while. Okay, this is playing tricks on me. There we are. So we have used a model, which I'll describe to you in a bit of detail, for 2 main purposes. This is a model where individuals inhale environmental allergens and we measure what's going on. And we do it, firstly, to understand the pathobiology and the consequences of airway inflammation in asthma. And secondly, to improve the efficiency of new drug development for asthma. And I'll spend a bit of time explaining what I mean by that. Now, the model I'm going to tell you about, again, has quite a history. And I want to talk about this extraordinary man, Herbert Herxheimer, who died in 1985. And that's the only picture I've been able to find. I've searched far and wide, and that is the only rather poor picture of Herbert Herxheimer. It was part of his obituary. Now, he was a German Jew who graduated in 1920 from Frankfurt University, and very wisely in the mid-1930s left Germany and moved to London to UCL, where he set up his research lab. He was extremely productive, and in 1951, published this paper, which the title of which was Bronchial Obstruction Induced by Allergens, Histamine, and Acetyl Beta Methacholine Chloride. And this is one paper of a number where he was focusing on inducing asthma attacks in individuals with mild asthma to look at the mechanisms of what's going on. He was the first to describe something we have focused a lot on, which is the late bronchial reaction, to describe it very carefully and in detail, what it looks like and how it develops and how it resolves. He was the first to show an effect of corticosteroids on induced asthma and bronchial hyposensitization in 1984. And his last paper he ever published in 1978 was published in The Lancet. It was a letter in The Lancet, and the title was, Should Asthmatic Patients Laugh? Now, this seems a rather odd thing to write a paper on, but in fact, it's quite pertinent, because when you laugh, most of us do laugh on occasion, you hyperventilate a little bit. And when you hyperventilate as an asthmatic, you can actually get bronchoconstriction. It's one of the stimuli for bronchoconstriction. So he was identifying the relationship between laughter, hyperventilation, and the development of asthma symptoms. What he really focused on in describing is something that we've now worked a great deal with in the lab, which is allergen-induced bronchoconstriction. So these are two examples of individuals, one sensitized to grass pollen and the other to house dust mite. If you take these people into the lab, as we do pretty well every day of the week, and give them the allergen by inhalation into the lung, you can, in virtually everybody, get an acute bronchoconstrictor response, the early phase response. It's transient. It lasts usually an hour or maybe an hour and a half. It gradually recovers back to baseline. And in perhaps 40 to 50% of individuals, that's it. Nothing else happens. But there are individuals, particularly sensitized to a number of different allergens, and I can explain why that's the case if anybody is interested. You get not only this early phase response, but you get something called a late phase response that begins usually between 2 and 3 hours, progresses over the day, and can continue 12, 16 hours, but because the lab is only working during the day, we stop the constriction usually between 7 and 8 hours. To do this, we have to study very, very mild, stable asthmatics. You cannot do this to somebody who is unstable. That's just too risky. They cannot be on regular treatment because the treatment itself influences the response, and they must be sensitized to an environmental allergen. So this time of year in September is almost our busiest time in the lab because we are actively recruiting our student body, 32,000 students who arrive on campus around this time of year, to find the right type of people that we can bring in to do these studies on. Another really important advance that was made in the mid to late 1970s, and it was made by Don Cockcroft, who I've mentioned as one of my heroes. He's an extraordinary individual and still active, was that the late response wasn't just finishing at 12 or 16 hours. It had consequences that went on for days and maybe weeks, which is allergen-induced increase in non-allergic bronchial, we call it hyperresponsiveness now, reactivity in those days. And this is the twitchiness of the airways to a non-specific stimulus. Methacholine would be a good example, histamine, cold, dry air, exercise, these things that cause constriction. The airways are much more sensitive. And this usually lasts a couple of weeks. So there are these longer-term consequences of just a 3-minute inhalation of the allergen in the morning of the day of the challenge. And when I was a fellow in the lab, again, many, many years ago, these two individuals were working there, both from Quebec, André Cartier from Montreal and Louis-Philippe Boulet from Laval. And they worked on this issue of the hyperresponsiveness in following allergen. And André showed that it was independent of airway caliber changes, but was correlated with the late response. Something was happening during the late response that caused this more persistent change that lasted a couple of weeks. And Louis-Philippe Boulet showed that this wasn't just a lab observation, that if you looked at people sensitized to ragweed during the ragweed season and measured responsiveness through the season, they got worse during the season. So it's a real event that occurs to individuals during an allergen exposure. Now, Gail Gavreau, who was a PhD student in the lab when she did this work, is now my colleague. And again, I'll talk about Gail a little later on. But part of her PhD thesis was to ask questions about the inflammatory changes occurring in the airways associated with the late phase response and the airway hyperresponsiveness. So this is one of the studies as part of her PhD thesis. She measured, first of all, methacholine airway responsiveness. That's the twitchiness I've talked about. And we did it at baseline. And in this study, the silver bars are inhalation of a diluent, just normal saline. And the green bars are the allergen in the same people. So it's a matched control experiment. This is the fall in FEV1 during the late response. It's about a 30%, 28% fall. And this is then the change in airway responsiveness that was still slightly increased even at 1 week following that single challenge in the lab. And Gail then, using a method that was developed in Hamilton by Freddie Hargreave and Peter Gibson, used induced sputum to look at inflammatory cells trafficking into the airways at 7 hours after the challenge, 24, 2, 4, and 7 days. And this is the influx of eosinophils. You see, it's about, it turns out, if we had this percentage, it's about 2% at baseline, increases to 10 to 15, sometimes 20% at 24 hours, and then gradually resolve. And an increase in metachromatic cells, which turn out to be basophils. So both eosinophils and basophils traffic into the airway and then resolve. And so it made eminent sense, at least to me, that somehow these inflammatory cells being recruited into the airway were actually responsible for the late response, with release of mediators, and maybe the persistence of these changes over time. And eosinophils clearly were the main target for this. So it seemed to make a lot of sense, and that was our hypothesis. It turns out to be absolutely wrong, but we'll come back to that in a few minutes. Now, I want to spend just a few minutes talking about how this model has been useful in drug development in asthma. And as you know, when we're developing new drugs, the first question that needs to be asked, is the drug active in the airway? There's usually a lot of data, preclinical data and models of this and that, but does the mechanism and is the drug actually active in the airway where you need it to be? So can it work? And that's usually a phase 2A study, small study in the lab, 20, 50, maybe as many as 500 in some big drug company studies. And then, of course, phase 3 is, does it work? The efficacy is a part of the equation. And then once it's approved, there are issues of effectiveness. Does it work well? How safe is it in real life? And efficiency. What is the cost of the drug? How does it relate to the benefits and costs? So all of these things we don't do at all, but we are very active here in doing these very early studies early on to decide, is a drug actually active in the airway? And is it worth going ahead with these much more expensive, larger phase 2B, phase 3 clinical trials? Now, I'm going to try to convince you that the model I've talked about, this allergen-induced change in airway caliber, airway hyperresponsiveness, and airway inflammation, is a very predictive model for efficacy of drugs in asthma. And there are a whole bunch of true positives. These are drugs that work really well in this model, and we know work well in asthma in one way or another. And there are some true negatives. So these are studies, these are drugs that have been studied in the model and have failed, didn't work in protecting the airways, but have gone on to big clinical trials in asthma and have failed. So the model was predictive of failure. And in fact, it's been predictive of failure consistently. There are a number of possible true negatives. These are drugs that have failed in the model and have not gone on to clinical trials. So we don't know whether this, in fact, is really. And there are a number of false positives. These are molecules, drugs that have a small effect in the model, but aren't particularly useful or not useful at all in asthma. So a positive study doesn't guarantee your molecule is going to work, but a negative study absolutely guarantees there are no false negatives. If it doesn't work, then really it's not worth the investment in spending money to take it beyond into phase 2B. And this, of course, is particularly helpful for small biotechs. And we've done a number of studies that I'll show you with small Canadian biotechs who really need to know how their investment is going to be used. And this has particularly worked well because of the, as you heard from Harris a few minutes ago, the allergen network of centers of excellence that was originally funded in 2005. And our esteemed leader is sitting right here, Judy Denberg, who led the initiative. And these people on the slide are the people, in my view at least, were mainly responsible for us getting funded and for keeping this funded for 14 years, which is the funding that we had, and actually pretty substantial funding for all of that time. So Peter Paré, our dear friend and colleague Malcolm Sears, Dean Beefus, who was there from the very beginning and was always a voice of thoughtful reason, excellent advice, and of course his science was remarkable. And Gail Gavreau, my colleague I've shown you a few minutes ago, her PhD work, and she's now my colleague at Mac, a full professor in the university, and leads, in fact, much of the work that we're doing. And what we did was we pulled together a collaborative. We called it the Allergen Clinical Investigator Collaborative. And it was led by Gail and myself at McMaster, with sites in Laval with Louis-Philippe Boulay initially, in Saskatoon with Don Crowcroft and Beth Davis, at UBC with the very late and lamented Mark Fitzgerald, our colleague who passed away a number of years ago, Irv Myers here in Edmonton, and Richard Lee in Calgary. And this came together for a very special reason, and that is that everybody at the early days, in fact, before Irv actually joined us, all of these people had trained in Hamilton. They had worked in the same lab. They had used the same methods. They knew the allergen challenge model. They knew its limitations, its strengths. And we were friends. We enjoyed each other. It was a lot of fun. We got together frequently. And so this seemed to make good sense. Louis-Philippe has retired, so Andriana Cote is now leading it in Laval, and Céline Bergeron is now the lead at UBC. And this is what we've done over the years. Studied a large number of molecules, some modifications of existing drugs, such as a non-steroid glucocorticoid receptor agonist, very interesting molecule that activates the glucocorticoid receptor but is not a steroid, and a whole bunch of new approaches, mostly protein antibodies, but not entirely, some small molecules as well. And the great strength of this for us is that because these are precision molecules with very specific targets, we are able to understand mechanisms of asthma, of these events, by using these tools. It'll tell us whether a certain molecule is in fact important in asthma. And we've had a lot of work over many years, and we've had a few positive, good things happen, and we've had one extraordinary breakthrough on this that was completely unexpected and has changed the way asthma is treated. So this has been a very productive and very enjoyable experience working with these colleagues. And today I'm going to choose two examples to show you, to tell you how it works. One is an antibody against an epitope called M1 prime, and I'll tell you why we study that. And the second one is an antibody directed against thymic stromal lymphopoietin, TSLP, or TSLP. And I'm doing these because one is a good example of a molecule that should not have gone into clinical trials, but did. And the second one is an example of where we found a positive test that changed the way asthma is managed. Now, to go back just a little bit, omalizumab, many of you will know, is an antibody that binds to IgE and prevents IgE binding to its receptor on mast cells and basophils and other cells that have IgE. And omalizumab was the first antibody approved for use in severe asthma, but in people who have severe allergic asthma. It was approved about 20 years ago now, 18 years ago. And the very first study to show activity in the airway was done not by us, I'm sorry to say, but by my colleagues at UCSF, Guillermo Boucher and John Fahey. And they used the allergen challenge model with this monoclonal antibody to see whether, in fact, giving the antibody systemically actually had effects on the airway. And this is their screening, early and late response, and the dark or the solid boxes is the treatment with the antibody, and the open is placebo. So they showed a marked reduction in free serum IgE, which is what you would expect. Total IgE actually goes up because when this binds to IgE, it doesn't get excreted as quickly, so total IgE actually goes up, but free serum IgE goes down. So that's the first positive. And secondly, when you do that, you reasonably effectively attenuate the early response and quite effectively attenuate the late response. So the model was used here to support this molecule going forward, and it did very successfully. So targeting IgE seemed to make sense. And a company that we worked with had worked on the idea of targeting M1 prime. M1 prime is an epitope that binds membrane IgE to IgE-producing B cells. It's only found in humans. It's not found in mouse models. And the thinking was, if you block this binding of IgE to the IgE-producing B cells, you stop producing IgE. And so IgE levels would go down, and if you have IgE levels going down, then the allergen response would be attenuated. So the cells that it was targeting were IgE-switched B cells, IgE plasmablasts, and IgE memory B cells. And the study design that we did is shown in this slide, which is we always do an allergen challenge at screening in every study to be sure the individuals who are then randomly allocated to the molecule or placebo have the responses we want. They then had these doses of the antibody at day 1, day 4 weeks, and 8 weeks, or placebo. And then we repeated the allergen challenge and then followed them out for another 4 months to look at safety. And the question we were asking is, first of all, did we reduce IgE? Obvious thing to do. And secondly, does that matter? Is that associated with attenuation of the early and late response? And the answer was actually quite interesting, because what I certainly didn't know is when we gave the challenge, this is at screening right here, day 0, and again at day 29 and day 54, whatever it is, we look at the allergen-specific IgE, the IgE to the allergen we were using in that individual. If it's ragweed, it's ragweed-specific IgE, or cat dander, that IgE. Giving the allergen challenge actually increases the allergen-specific IgE significantly. It's about almost a threefold increase and it persists for the duration of the study. And giving the antibody MEMP 1972 completely ablated that. So we knew from that data, this antibody, in fact, does get into the airway, and it's preventing this allergen-induced, allergen-specific IgE increase. But the total IgE, which went up a little bit, you see about 140% of baseline, was also blocked by the antibody. For irrelevant allergens, nothing much happened. So very, very positive data. We thought this was going to be of some interest. But unfortunately, when we looked at the early and late response, this is the screening study I told you, early and late response. Day 86, which was the primary outcome variable, there is no significant attenuation of the early phase response. Now, if you're going to block IgE, you would expect there to be an effect on the early response, and it did not happen. And there was a small but just marginally significant effect on the late response. So the interpretation for us was that very interesting. This epitope clearly is important in inducing the allergen-specific changes, but the magnitude of effect on total IgE was not sufficient. If you compare it, the allergen, the specific, the free IgE, for example, to omalizumab, quite strikingly different. But the company went ahead and did a big clinical trial, even though the data that we presented were negative. And I won't go through all of this, but suffice it to say, trial was negative. No effect overall in asthma, and so this molecule has disappeared. Now, there's still questions about this. What happened if we had treated for a year, not for 2 months? You know, could you over time go? We don't know that. We don't know that. But within the limitations of developing a drug for asthma, you can't have a drug that takes a year to work. That's just not a non-starter. So this basically was the end of that story. The more positive data comes with our work looking at epithelial alarmins, specifically TSLP. As you all know, I think, they are epithelial, we thought, only epithelial-induced. That's actually not true. And when they are released in response to a stimulus, viruses, atmospheric pollutants, allergens, they have a downstream effect on inflammatory cells. And all of the molecules that we now have to manage severe asthma, which block omalizumab, I've talked about, drugs that inhibit the binding of interleukin-5, mepolizumab or rezolizumab, drug that binds to the IL-5 receptor alpha, benralizumab, and drugs that block IL-4 and IL-13 by binding to the IL-4 receptor alpha. These are all downstream. So interesting question was, could blocking some of these alarmins upstream actually have an effect that would be broader, if you like, than the specific targeting of downstream molecules? Now, an interesting story about this, because the molecule I want to tell you about is called AMG 157. And I was giving a talk, many, many years ago at the American Thoracic Society, or it might have been the Quad AI, I don't actually remember. But at the end of the talk, somebody came up to me, as sometimes they do, and say, thank you, nice talk, yeah, always nice to hear that. But he said, we have a molecule, Amgen have a molecule that is very effective at binding TSLP. And he said, I've spent 9 years of my life working up this asset, and we've done a small clinical trial in patients with severe allergic dermatitis. And the thinking was, it's a disease that is TSLP driven, there's lots of animal work in that, but the early study failed. And so this molecule is going to disappear into the vaults of Amgen, and the other 100,000 molecules they have are going to be evaluated. So he said, would it be interesting to you to actually study this in your model? Now, at this time, Judah and others had been interested in TSLP and had done some work on the basic mechanisms of TSLP. And so we sort of had, yeah, this would be kind of interesting. So we did the study. And this is this is the design of the trial. Excuse me, as I mentioned, we always do a screening. So the screening is a triad. They come in the day before the allergen, they get all sorts of measurements made, blood tests, lung function, airway responsiveness measured. They have the challenge, and then the next day come back and everything's repeated. And they wash out, usually for 3 to 4 weeks, start the treatment, dose day 1, another dose day 29. Day 42, we repeat the triad, 41, 42, 43, another dose, and then final challenge on day 83 to 85. And the study was quite remarkably positive, if surprisingly so. So this is the screening, early and late. This is day 42. And you can see there's about a 50% attenuation of the early response, which was entirely unexpected, frankly. We didn't think TSLP, I didn't think, I shouldn't speak for my colleagues like Dean, he probably knew this, but that TSLP had effects on mast cells. This is a mast cell-driven response. So that was news, And then there was significant effect on the late response, and this actually looked very similar to the omalizumab data that I had shown you way back when that was being evaluated. So good news, it's a positive effect, and there's some new information about effects on mast cells. But the really shocking data, for me at least, came when we looked at the biomarkers that we measure repeatedly in these studies. We measure blood eosinophils. And blood eosinophils in these mild asthmatics are always slightly elevated around 300. And we measure sputum eosinophils consistently. And they're always elevated between 3 to 5% at baseline. And we measured exhaled nitric oxide, which is a biomarker of a perturbed epithelial function. And that was elevated in the group between 40 and 60 parts per billion. We gave the first dose of the antibody. The red dots are the individuals getting the active drug. The blue is placebo. And after the first dose on day 1, already by day 8, if we look at FeNO, it's the one we measured most frequently. It's the easiest to measure repeatedly. Already by day 8, there was a significant reduction in FeNO levels. And by day 29, everybody was normal. There are no error bars here because everybody normalized. And the blood eosinophil counts by day 29 had gone from 300 to 150, and the sputum eosinophils from the baseline of about 4% down to 0. So a single dose of this antibody completely corrected all of the biomarkers, but in very mild asthmatic subjects. That was really quite shocking. And the only interpretation we can take away from this is that TSLP is constitutively released from the epithelium, even in the mildest patients we can find. And blocking that corrects all of the biomarker increases that we see. And then when we gave the challenges, day 42 and 84, you see the effect on abolishing the allergen-induced eosinophilic changes and the increases in FeNO. So not only baseline reduced, but the allergen-driven responses were also inhibited. This is now a drug called tezepelumab, which is the most recent biologic to be released in asthma. This is the large phase 3 clinical trial looking at severe asthma exacerbations as the primary outcome variable. The overall effect was about a 56% reduction in severe exacerbation rates. And for the first time, in fact, for any biologic, this effect was even seen in individuals with a blood eosinophil count under 300. Every other biologic, with the other 5 we have, only work in individuals with high blood eosinophil counts. You take people in with lower counts, you don't get any benefit in exacerbation risk. But here there was a reduction of about 40% reduction. And for the high eosinophil numbers, it was about a 70% reduction in exacerbation rates. So the drug is now available. It's being used quite widely worldwide for the treatment of asthma. So when we look at the drugs we now have, this is a wonderful review article by Guy Broussel from Ghent in the Netherlands, in Belgium, describing the various antibodies that we have to treat asthma and the different classes I've talked about, the most recent being this upstream inhibition of the antibody. And the early days of the studying of these antibodies, because of the effect of omalizumab I've shown you, included a study, it published in 2000 in The Lancet, that used the very first anti-IL-5 monoclonal antibody called mepolizumab. And I won't go through all of this. It's not a particularly good slide from the paper, but the study was negative. The antibody did reduce blood eosinophils, as you would expect it to, but had no real effect on the allergen-driven responses. The study was led by a woman called Margaret Leckie, who was a respiratory fellow in London at the time. Maggie then joined us in Hamilton as a rheumatologist. She got married to Mark Larcher, and now Maggie Larcher. And I've always felt a bit guilty. I see her frequently. She's moved to Calgary now, by the way, so she and her husband are now in Calgary. Because when this was published, I published with 2 colleagues, Mark Inman and Param Nair, a rostrum in Jackie saying this study was rubbish. It was badly designed, actually probably true. The statistics were poor, really true. They used really inappropriate statistics, and said this does not, because the study was interpreted as eosinophils are unimportant in asthma. They come in during this allergen response, you can get rid of the eosinophils, nothing happens to the allergen response, eosinophils are unimportant. Absolute nonsense. So every time I met Maggie, I felt slightly apologetic. I didn't mean to be so cruel and so on, but at the time felt very passionately because people's grants were being turned down because eosinophils were irrelevant in asthma. But I had this burning need to repeat the study. Is this actually true or not? And so we did, and this is just published online a few days ago. Gail Gavreau and a whole bunch of colleagues in the CIC helped with this study. And in this study, we used not mepolizumab, but benralizumab, the molecule that binds to the receptor IL-5. It causes apoptosis of eosinophils as well as inhibiting their production. It clears eosinophils away from every compartment, but we wanted to measure that. So in this study, we looked at blood fairly easily. We did bone marrow aspirates in these subjects on 3 occasions. And this is because of work I've done for several decades now with Judah, with a particular interest in the eosinophilipoiesis in the bone marrow, trafficking from the bone marrow into the blood, into the airway, and the idea of in situ eosinophilipoiesis, which we have shown to be the case. Judah and his lab have shown to be the case. So we do bone marrows. This wasn't all that unusual for us, but still you have to get a very accomplished and skillful hematologist who's good at this to actually take it's not a biopsy, by the way, it's just an aspirate. We collected sputum, we do that all the time, and we did bronchoscopies to take airway biopsies to make sure the cells were gone from the airway. So the red is the benralizumab over 20 weeks of treatment. We did a challenge at week 9 and another challenge at week 12, and the gray is the placebo treatment, double-blind placebo-controlled trial. So blood eosinophils vanished, basically. No eosinophils in the blood through the entire challenge. Bone marrow eosinophils done before and after the week 9 challenge, 0. No eosinophils, no eosinophil progenitors, as it turns out. Sputum done at week 9, no sputum eosinophils. And in the airway biopsies, fewer eosinophils, harder to measure, but we couldn't find eosinophils in the biopsies. So as best we can tell, using this methodology, we have wiped eosinophils out of these individuals. So of course, this was going to markedly influence the early and late response. It did not. This is the early phase response. This is the late response with placebo and with the antibody. I'm not showing you data, but it didn't influence the allergen-induced airway hyperresponsiveness. None of the physiological variables were influenced at all. So I'm now thinking of writing a rostrum to Jackie, and the title would be Maggie Was Right, to own up to my hubris way back, thinking that, in fact, this was incorrect. In fact, it was absolutely right. Study wasn't good, the statistics weren't good, but the answers were the right answers. So this then now begs the question, what are these cells doing in the airway? They come in, 20% of the sputum cells are eosinophils. They're activated as best we can tell. We can measure all sorts of eosinophil proteins and so on. What the heck are they doing in the airway? So this study has made me stand back and say, you know, these assumptions one makes looking at associations, you have to be very careful in science. And just the temporal association of eosinophils, the fact that eosinophils are very effective cells at doing all sorts of things, getting rid of parasites and everything else, but yet here in this model at least, we can find no benefit of getting rid of eosinophils. So that then brings us full circle. The 1984 paper is now right back again to mast cells. So are mast cells driving all of these responses? Certainly the early response. I think that's quite clear. Maybe the late response, possibly. The hyperresponsiveness, we don't know. Influx of inflammatory cells, we really don't know. It's not being carefully studied. And how important are mast cells and targeting mast cells in the big picture of asthma? We really don't know that yet. All of the work has really been focused for the past 2 decades on eosinophils, what they do, and how to block them. And that isn't to say eosinophils aren't important in asthma. They clearly are, because the anti-IL-5 receptor, the anti-IL-5 that binds to the protein, and all of the biologics, they only really work in people with eosinophils in their blood and in their lung. But the other side of that coin is you can have a lot of eosinophils in your blood and in your lung and have no symptoms, have no asthma. It's not, it may be necessary, but it's not sufficient to induce this. So what are they doing and how are they working? So now our focus for the next study in the CIC is going to be targeting mast cells and trying to get rid of mast cells and then see what happens in the same way. So I'm going to summarize by saying the model is well established to study mechanisms of allergic asthma and possible new therapies for asthma. It has a very high negative predictive value, but a less good positive predictive value for the new treatment approaches for asthma. The reliability of the model allows studies to be done with a small sample size. So all of the studies I've shown you have been under 40 individuals, but they're done very carefully in very carefully phenotyped individuals. That allows us to do that. Allergen-induced airway eosinophilia is not the cause of allergen-induced bronchoconstriction or airway hyperresponsiveness following allergen. And a new study we're just getting underway is going to target mast cell survival using anti-CKD antibodies to see if by getting rid of mast cells, we can show the effects we expect to see. Once again, finally, want to thank so many colleagues in Hamilton, Gail, Kieran Killian, Judah, Roma Semi, my colleague Pram Nair, and Imran Satya, the various fellows that have been with us for the past 2 or 3 years, 3 or 4 years in the lab, the techs in the lab, and my colleagues in the CIC were so important to getting these studies done. Thank you.
Questions for Paul? Thank you very much.
Thank you, Paul. Miss you, by the way.
It's an excellent presentation. So I don't know if there are any questions in the room. Right at the back.
I'm one of the allergists in the hospital. Actually, I graduated with a master, but I don't think the academic prowess rubbed off on me. But I'm wondering, in the inhalant challenges, are you using, what kind of extract are you using as the inhalant? So is it the extract we use to get skin test?
Yes, the same allergen we use in skin testing.
Can we get the question just for people online?
Sure.
Just repeat this question. Yeah.
I think I'll do my best to repeat what you asked, but is the allergen we use for the inhale challenge the same allergen we use for skin testing challenges? And the answer is yes, it is. And in fact, Don Cockcroft has done a lot of work in this, and we use the allergen skin test titration as a way of establishing the doses, the inhaled concentration to begin with to develop the response. And we also select the allergen based on skin test responses as well as the patient's history. So sometimes, you well know, people are polysensitized, so you have to be a little careful which of the allergens you select. No, never, never. Not in gosh, more than 40 years of doing the challenges, both in at the Firestone Institute and in my lab at Mac. Thank goodness, touch wood, never a single time. But we're very cautious and careful how we give it. And it's a little different to food allergies, where I think you are, a food allergen challenge, where you are at much greater risk of an anaphylactic reaction.
Lots of time.
Thank you so much, Paul. That was wonderful. I have 2 questions. One, why has it taken so long to do the anti-stem cell factor? Why wasn't that done much earlier, given that we thought so strongly about the early phase reaction?
Yeah. Yeah, it's a really good question. And I think it is probably best answered by enthusiasm of pharma companies, quite honestly. And at least in asthma and in other manifestations of allergy, the skin, of the nose, and the eyes, there's been a huge focus on eosinophils, investment in that. How well does mepolizumab work in the skin? How well does benralizumab work in the nose? These kinds of questions. And the development of anti-stem cell factor antibodies has, as best I can tell, been about 3 to 5 years, but again, mainly focusing on the skin.
Yeah.
A severe allergic dermatitis or chronic urticaria. And in fact, there's now some early reports showing benefit in the skin. And because of that, we then get calls.
Yeah.
We've had 4 calls in the past month, Gail or I, with companies who are now excited about getting into the business. So I don't know what the right word is, but there's sort of a herd mentality here. People see a positive response and suddenly they have all sorts of ways of attacking it.
Yeah.
So my view is, Dean, better late than never. Right? So we're now getting into it.
Thank you. I'll actually pass it on.
Judah. Okay, thanks. That was wonderful, Paul. Thank you. I wonder if you could tell us where you think the uncoupling is, because you show very nicely that the lung early and late phase is not affected, but then we know that the exacerbation rates are affected. So there's something about the reaction and then the trajectory of disease.
That is the $64,000 debt in my view at the moment.
That's why I asked you.
Yeah. And I am bugging my colleagues who know these areas much better than I do, including my colleague sitting right here, Roma Semi, and others who spend a lot of their time thinking about eosinophils, eosinophilophoresis, basophilophoresis, what it works, what it means. I have to confess to you, I was initially a bit disappointed when I saw the data. But then I realized, like, best science comes from data you are completely unexpected. That's all, completely unexpected. So our challenge now is to start thinking about these issues. Are all eosinophils the same? Almost certainly that's not true. And we're now identifying various subsets that might work in different ways. What is it about just having the eosinophil in the airway? I mean, just having them there isn't enough. We know that for sure. You know, what's the second hit? What's the result of that second hit? Is it a virus? Could well be a virus. You know, it's setting the airway up to respond in a certain way. But it's just opening up all sorts of interesting questions now, which I think is really exciting. But I don't know is the answer. It's the short answer.
Thank you.
So, Paul, that was fantastic. And your laryngitis disappeared. So there you go. That's a therapy. I think what Lisa asked you and what you answered is the direction forward.
Yeah.
The same way that we were engaged for years with John Bienenstock in defining and agonizing over mast cell heterogeneity needs to be taken into account in eosinophil heterogeneity. I've attended many IES seminars, webinars. We had a conference of the IES. An eosinophil is not an eosinophil, and even if you're targeting the bone marrow, and some of the data I'll show today, there are funny cells still there in those colonies. We called them basophil eosinophil colonies. What's the transition between the basophil and the eosinophil? What is a resident eosinophil? What's an inducible eosinophil? And how do they play a role in this? So to the extent to which you can incorporate that into the next challenges would be excellent.
Thank you for that. I very much agree. We had dinner last night. I'm sorry, I don't remember your first name.
Adil.
Adil, yes. Thank you. I'm sorry about that. We had dinner last night, and Adil was asking me about whether there's any future in studying asthma. And I said, absolutely yes. There's a lot we still need to learn about, just like this. Yeah.
Thank you very much. This was a fantastic lecture. And, you know, I am asthmatic. I can tell you that, yes, when I laughed as a child, I got asthma attack. So I agree with your, yeah. And I have also a memory because in 2003, 2004, I was a postdoc in Modena in Italy. And my former chief organized the GINA meeting. And I remember one thing I remember because I didn't understand anything about it because I was not working with asthma. But after your lecture, he said, Paul is the best. And now I understand why. Because you are a physician, and it is my understanding you don't have any formal training in basic science. But you navigated wonderfully. So the first question is, how important it is for today's clinicians who wants to be researcher to do that, to take into consideration that. And the second thing is your ability, or I don't know how to describe it, to navigate also the relation with small, medium enterprises and even giants, still remaining consistent and true to yourself, right? So how important are these two factors in designing a career today?
Well, firstly, thank you for the compliment. That's very, very generous, very undeserved, I'm sorry. But I cannot emphasize enough how important being at McMaster has been to me and my career. It's an unusual place, very unusual place, because it values collaboration in a way that not many other places do. And so I have no really formal training in basic science at all, clearly not. I spent a lot of time at CVR, a couple of years CVRI, and they were always, you know, talking about basic science. You absorb a little of it, but truly no. But I'm surrounded by people who are really good at this stuff. Sitting right here as an example. And Dean, and Roma, and Gail, and on and on and on. And we really value working together first of all. And secondly, it develops a level of friendship and engagement that's quite unique, I think. So, being a clinician, and I need to understand what it means that if you are able then to link yourself with these exceptional people and develop close, engaged collaboration, that's the only way to do it, in my opinion. Trying to do it all by yourself or trying to, bring students in who are very talented and often very good, I don't think you move the needle all that far. And that's one thing I would try and encourage, if at all possible. When Adil and I were talking last night about the mentorship you can get, about the support you need, and the fact that you need to be able to learn what others are doing, sure, and try and understand it, but engage them in your research. And if somebody like this young fellow here, who is one of the world's best at what he does, and engaging this kind of activity, that's the only way you're going to be able to move forward. Now, I've spoken so long, I've forgotten the second question.
That's okay. How to navigate the relation with industry?
How do we manage this with industries? So I can tell you what I've done. I'm not necessarily the only way to do this. But we have this model, and it's now quite well known that we here in Canada do this in a way nobody else in the world does. So there's a lot of interest in coming in and being involved and sharing with us. But we need to access or to have access to molecules that we're interested in, that teach us about the mechanism of disease. And we need free and full access to all the data. Those are minimal criteria for working with us. And it's surprising. People say, yes, absolutely, no problem at all. I personally have never been worried very much about the way industry, even the big companies, analyze and handle data sets. I mean, you can find odd rogue individuals here and there, but by and large, they manage data in a way that I don't think we at universities actually do all that well. Quite honestly. The problem they have is interpreting that and the marketing of those data sets. That's where the problem is, and that I try to fix on. Don't get involved in that.
So I think we've come to the end of our time now. So I'd like to thank you again, Paul, for an excellent lecture.
Very good.
Just to remind everyone that the second part of the day, the main seminar is happening in the Oborowski lecture or seminar hall in the Li Ka-shing building. We're going to try and get started at 9:30. There also will be some breakfast over there. So encourage everyone to go and enjoy the rest of the day.